We are open for 1 or 2 questions. Do you have any? So for John, I have a question for you. In Brazil, the trauma centers, they have like a rule for the residents, when you call them. Okay, with 3 fractures, okay, admitted the patient. No, 1 or 2, not only if you have talking about fractures. You have these rules or something similar in England?
So I think the front door assessment and referral practice is something that's very important if we're going to move towards rapid access to surgery in appropriate cases. But rapid access to conservative management also is very important. And I think this is where having a unified taxonomy that can be applied, can be distributed, just as for those of us that deal with lung cancer staging, there are the staging cards. I have them in my briefcase. You know, these are the sorts of things that I hope that we will be able to distribute to our radiologists, to our ER physicians, so that the people that are first seeing the injuries are able to assess correctly and then make the appropriate type of referral. So I think, you know, that is the very first step in the process of both operative and non-operative management, is to assess the patient and make sure that they are classified correctly.
And for Fred, sorry, please.
Dietmar Kraus from Nuremberg in Germany. A technical question. For 5-rib flail, dorsolateral, would you fix every rib, and how do you manage, would you manage the dorsal aspect of the ribs?
You can read.
So the question was a 5-rib lateral flail with a 2 fracture series. Would you fix every rib as opposed?
With relation to the paravertebral segment.
Yes, so it's a good question. I think there are 2 separate issues. Do you need to fix all of the fractures? Meaning, do you need to fix the highest and the lowest fracture, or do you need to fix enough fractures that you would turn the flail into a non-flail, meaning just one of the 2 fracture series? Not a ton of great data. The best I know of are out of Australia. Silvana Marasco looked at scans in patients in whom both fracture series were repaired, compared to those in which only the anterior fracture series were repaired. And in a significant portion of patients, there was interval displacement of the posterior fractures and bony bridging between fractures healing to the incorrect segments. And she measured PFTs and saw some restriction of the pulmonary function. So my practice is to repair both fracture series and to repair each rib.
Thank you.
Kieran McManus from Belfast. John, you've put a lot of effort into defining displaced ribs and the amount of displacement. But if you listen to Dr. Parachi, you know, he probably agrees with me that the difference between an undisplaced rib and a displaced rib is about 48 hours. So how do you reconcile that with your taxonomy?
It's a very good point, and I think the key to this is trying to get data. There are some good studies out there. So there is a paper in the European Journal from nearly 20 years ago looking at the effect of the muscle serratus anterior in causing bucket-handled forces and displacement. But knowing what happens when we do nothing, it is opinion at the moment. And I think the important factor here is for us to try and get data to inform what actually happens. And hopefully with the new Chest Injuries International database that CWIS will be launching very soon, we'll be able to look at non-operative cases as well and learn what happens to these patients. There's a lot of opinion. I think we need data to answer that sort of question.
Thank you.
The last one, please.
Thank you. Hernando Trancho from Madrid, Spain. I'm just asking about early stabilization of the direct fractures. Any concern about age, comorbidities in frail patients and patients under anticoagulant therapies?
So excellent question. The age question is very interesting because many of us who started fixing ribs regularly would shy away from elderly patients because of risks of osteoporosis and debilitation. My practice has done a 180 reversal, and that I am most aggressive in offering the surgery to elderly patients because I feel like they have the smallest amount of reserve to get through the pain of rib fractures. And many, myself and many of my colleagues, at least in America, have regularly performed rib fixation in patients in their 90s, and even the oldest patient in whom I've fixed was 101 years old. The anticoagulant issue is an interesting one. Again, I feel like stabilizing the rib makes it less likely to bleed and less likely to injure an intercostal vessel. So I have no problem proceeding directly to surgery in patients on either anticoagulation or antiplatelet therapy.
Thank you.
Thank you for all. And